Dr. Justin Newman with Orthopedic Centers of Colorado, presenting our technique for autologous bone fill of bony defects in the setting of revision stage ACL reconstruction. When we have the ACL, which cannot be placed anatomically, particularly in the setting of multiple reconstructions, in order to afford better infill of these tunnels, we've switched to using this technique. We can see on the CT scan the large cystic tunnel, and at 4 months the bony infill in this area. The approach is very similar to a retrograde femoral nail. A small medial parapatellar arthrotomy is typically utilized. However, we will liberally extend this in order to mitigate any risk of iatrogenic damage to the joint. Upon initial arthroscopy, we see a large cystic tibial tunnel. It's important with this technique to remove all soft tissue, any previous hardware, and we'll carefully resect any of the sclerotic hard margins of bone about these tunnels in order to afford the most adequate biological environment for the rapid in-heal of this graft. The placement of the reamer is very typical to their pre-described technique. We will place the opening guide pin both with fluoroscopic as well as arthroscopic visualization. We're ensuring that we are avoiding the fibers of the PCL and in an area that will have minimal chondromalacia or impact to the trochlea. The guide pin will be placed. The opening reamer will then be placed. We will typically undersize this approximately 1 millimeter, as we find that since we are not placing a nail in order to minimize our footprint, that the rhea will still pass through a relatively smaller tunnel. Ball tip guide wire is then placed in standard fashion. The rhea, per their technique, is then introduced. This is slowly advanced and then brought back in order to afford the suction to collect the bone graft in a canister, which is attached to the suction. The amount of bone graft that we are able to obtain is usually of excellent volume and quality. Checking for engagement of the patella within our defect, we see that even in terminal flexion, we are not engaging into this defect, and we've had very minimal to no issues with this. The bone is then passed through a simple technique. We'll take a 3cc syringe, cut off the tip. This allows our assistant to repetitively fill this with graft and bring it up to the field, and we find that this will fit through a modified arthroscopy portal. We can see with the tibial tunnel being packed, the nature and quality of the graft, which is excellent for packing into the tunnels. We'll typically pack this in firm fashion in order to ensure complete fill and in order to speed the rate at which we're able to heal this and then come back for the second stage ACL reconstruction. We'll oftentimes then also use a thin layer of Tecile as we pack this up into the joint with the Tecile to seal off the aperture. I believe this helps to decrease the risk of the postoperative hemarthrosis washing some of this graft away. Repeat arthroscopy at approximately 4.5 months demonstrates effectively normal appearance of the bone. We are then able to ream our tunnels in standard fashion. As you look at the tunnel, we'll see that there's still some healing going on. It doesn't have a perfectly normal appearance from the coloration, but we've effectively restored this to normal bony anatomy and normal cancellous bones, which allows us to perform our ACL in our anatomical fashion. Looking at the tibial tunnel, very similar. We see excellent infill about our new tunnel. Thank you.